Enlarged peripheral lymph nodes occur with lymphoid and plasma cell hyperplasia, inflammation, or lymphoid or metastatic neoplasia. Although cytology of lymph nodes often provides an accurate diagnosis, in some cases biopsy, immunophenotyping, or clonality testing may be helpful for further evaluation. A 21 to 25 gauge needle, with or without a syringe, is used to collect a sample for cytology. Only a small amount of material is needed, and this is gently expelled onto clean glass slides and dispersed with a spreader slide. Common errors include failure to adequately disperse the cells, resulting in smears that are too thick, and applying too much pressure, resulting in broken cells. Slides should be clearly labeled and allowed to air dry prior to staining. Slides should not be stored in a refrigerator or be exposed to formalin fumes. Slides can be stained using Romanowski-type stains like Wright stain, Wright-Giemsa stain, or commercially available quick stains. Normal lymph nodes are characterized by a heterogeneous population of 80 to 95% small lymphocytes and 5 to 20% intermediate and large lymphocytes. Small lymphocytes are smaller than neutrophils, have scant light blue cytoplasm, and a high nuclear to cytoplasmic ratio. Nuclei are round and have dense, coarsely clumped chromatin and inconspicuous nucleoli. Intermediate lymphocytes are similar in size to neutrophils and have moderately condensed chromatin and a moderate amount of basophilic cytoplasm. Nucleoli may be visible. Large lymphocytes are larger than neutrophils and have stippled chromatin, 1 to 2 nucleoli, and variable amounts of basophilic cytoplasm. Plasma cells, macrophages, and occasional mast cells are present in most normal lymph nodes. In hyperplastic lymph nodes, intermediate and large lymphocytes are increased, but comprise less than 50% of the lymphocytes. If more than 50% of the lymphoid cells are intermediate or large, lymphoma should be considered as a differential diagnosis. Hyperplastic lymph nodes often also have increased numbers of plasma cells, and these sometimes are referred to as reactive lymph nodes. Neutrophilic inflammation involving lymph nodes is relatively uncommon and can be associated with bacterial infection, necrosis, or immune-mediated diseases. Fungal, protozoal, and mycobacterial infections are associated with increased numbers of neutrophils and macrophages. Eosinophilic lymphadenitis is uncommon and can occur with parasite infections, some fungal infections, mast cell tumors, lymphoma, and metastatic carcinomas. Lymphoma is the most common hematopoietic neoplasm in dogs. Most dogs present with multicentric lymphoma, characterized by non-painful, generalized peripheral lymphadenopathy. Neoplastic lymphocytes usually are greater than 90% of the lymphoid cells. Neoplastic lymphocytes rupture easily during slide preparation. Only the portions of the smear where intact cells are adequately dispersed should be evaluated. Aspirates of popliteal and prescapular lymph nodes are preferred because mandibular lymph nodes often may appear hyperplastic. Although cytologic classification of lymphoma is not as reliable as histologic classification, it may be sufficient to recognize common cell types. Most dogs have high-grade tumors, which usually involve intermediate to large lymphocytes with basophilic cytoplasm and round to irregularly shaped nuclei with fine chromatin and single or multiple nucleoli. Low-grade tumors often involve small lymphocytes with scant cytoplasm and round nuclei with condensed chromatin. Low-grade tumors are less aggressive and have a better prognosis than high-grade tumors. Cell morphology does not have a high correlation with whether there is a neoplastic proliferation of B or T lymphocytes. The cytologic diagnosis of lymphoma may be difficult early in the disease if there is atypical hyperplasia or if the neoplastic cells are small or intermediate or otherwise atypical. In these cases, histologic evaluation may be necessary. Immunophenotyping by flow cytometry and polymerase chain reaction for antigen receptor rearrangement may be helpful in determining whether the cells are B or T lymphocytes and if there is a clonal expansion of lymphocytes. In general, dogs with B-cell lymphoma have longer survival compared to dogs with T-cell lymphoma, but clinical presentation, breed, anatomic site, and laboratory findings also may affect prognosis. The most common form of lymphoma in cats involves the gastrointestinal tract. Neoplastic lymphocytes often are small, nuclear chromatin is condensed, and nucleoli are inconspicuous, and there is minimal cytoplasm. In these cases, biopsy or clonality testing may be helpful in supporting a diagnosis of lymphoma. In some cats with gastrointestinal lymphoma, there is a neoplastic proliferation of large granular lymphocytes, which are T lymphocytes characterized by azurophilic granules in the cytoplasm. These granules usually are prominent when stained with right stain, but may be less apparent with commercial quick stains. The significance of immunophenotype and prognosis in cats with lymphoma is unclear. Lymph node aspirates sometimes are evaluated for evidence of metastasis from mast cell tumors, melanomas, histiocytic sarcoma, carcinomas, and sarcomas. If numerous metastatic cells are present, cytology is helpful. However, the absence of neoplastic cells on cytology does not preclude the diagnosis of metastasis. Histopathology is more sensitive in the detection of metastatic disease.